Okay, now for our presenter, Dr. Kristin Torre received her undergraduate degree in biology from Boston College, where she graduated with summa cum laude and Phi Beta Kappa honors. She completed her medical degree at University of Connecticut School of Medicine, where she was elected to the Alpha Omega Alpha Honor Society. She received her internship from Yale Internal Medicine program at Waterbury Hospital, returned to UConn to complete her dermatology residency. While there, she served as chief resident in her final year and published many peer-reviewed articles in leading dermatology journals. And she's very excited to be practicing dermatology in the home state of Connecticut in Oxford. So, and there is an office right over here too. Yeah. In Shelton, I go to that. So welcome. Thank you.
Thank you for the intro. So I'm from Connecticut, from New Fairfield, actually. It's about 50 minutes to the west. But I practice now in Oxford. We have this new office, part of Derm Physicians of Connecticut. It's beautiful. And we're welcoming all new patients. So what we're going to talk about today is skin cancer and skin care. We're going to kind of go through skin structure, skin cancer, which is probably what you're all really interested in, what they look like, how to diagnose them, prevention, common skin lesions, and then products. So the skin, everyone knows, the body's largest organ. It's my favorite organ. It does everything. It protects, it regulates temperature, it stores water, it stores fat, it's sensory, it just does a ton. It prevents entry of bacteria, it protects us, helps make vitamin D, and it acts as a big barrier between the environment and our bodies. So skin cancer, we all have heard about it. It's the most common cancer worldwide. Greater than 3 million people are diagnosed in the US every year. So it boils down to about 9,500 people per day, which is a really outrageous number. 1 in 5 Americans will develop skin cancer in their lifetime, and it can affect anyone, regardless of skin color, anyone. 3 main types. So basal cell, squamous cell, melanoma. We'll kind of go into each one of those. So basal cell is the most common, and melanoma is the least common, but the most deadly. So basals and squamous, they're highly curable if they're detected early and treated appropriately by a dermatologist. Melanoma, if you get it early as well, has a great survival rate. 5-year survival is 99%. Only 4% of melanomas, when they're diagnosed, are metastatic. So you really want to get them early. So risk factors for skin cancer. So it affects pretty much, all different types of people, but higher risk factors in light skin, blonde hair, red hair, blue or green eyes, older age. We see patients who are, advanced age get more skin cancers, personal or family history of skin cancer, tons of moles or unusual looking moles, extensive exposure to the sun, especially UV tanning beds, and greater than 1 severe sunburn in their lifetime, which includes like a blistering sunburn. So this is the most common form of skin cancer, is a basal cell. I see these all day long. They are, anyone can get these usually from the sun. They're usually pink, pearly bumps or a pinkish patch of skin. I'll show you in the next few slides. They can look like anything though. So, this is the most typical, but there's a ton of variants. They usually develop after years and years of sun exposure or indoor tanning. They're really common on head and neck, even the chest, but they can be anywhere on the body. And you really want to diagnose these early because although these aren't very deadly and the metastatic rate is like 0.1%, they can be very destructive. So people can have really large basal cells on their back, usually if they're left untreated over years and years. So these are some examples of basal cells, just to give you an idea. So that was the first one we saw there. So that's your classic. But they can look like this, and that just looks like a scab for most people. But that's a superficial basal cell, very early top layer of the skin. We can treat it very easily. Really doesn't cause any destructive nature, but if left untreated, it'll just get bigger and bigger. The one on the bottom is actually a pigmented variant. So you have pigmented basal cells. So that actually you could have in your differential melanoma there, but that is a basal cell with some pigment in it. The top one is probably the most aggressive form of a basal cell. It's a morphiiform basal cell, which looks like a scar. So you could tend to miss that. But those are usually the most aggressive. Basal squamous on the bottom here, that's a combination of a basal cell and a squamous cell skin cancer. These tend to be scaly, they tend to be bigger, a little bit more aggressive as well. This we see a lot in our elderly population where they have these kind of crusted nodules, either on their ear or their face. But this top one is a nodular basal cell, it goes a little bit deeper. And then we do see them on the eyelids as well. So this bottom picture, is a picture of a basal cell on the eyelid of a patient. They're easy to miss, but you want to definitely make sure you're looking at everything, ears, eyes, all over the body, because these can develop anywhere. Same thing with this top one, another pigmented basal cell. You've probably seen people kind of walking around with these things growing on the face, and these need to be treated because again, it's getting really, really close to the eye. And we treat these with Mohs surgery. So it's skin sparing surgery. So you don't want to take any of that eyelid tissue. The bottom one is another type of basosquamous. So the basal and squamous combined. And then again, the top one kind of looks like a scratch, but a superficial basal. So anything that looks pink, really not healing, looks like it's bleeding, growing. I always tell my patients to call the office and we'll take care of it right away. Usually needs a biopsy. Same thing with the bottom one is a nodular basal cell, has a lot of prominent blood vessels, and that's more classic of that pink pearly papule that we see. So what to look for? New, anything new. So I tell my patients, if you have something new, just call me because, you never know what it's going to be. And for them, it's hard to differentiate what's good and what's bad. So anything new, growing, bleeding, changing, itching as well. If it bleeds when they shave or there's a history of them saying this thing bleeds and I don't even do anything to it, I tell them to come in. Non-healing is really another clue. And then change in color and size as well for basal cells. But this is the most common skin cancer. I see this all day long. And a lot of patients come in with this. So transition to squamous cells. So these are the second most common, but they look more like volcanoes or craters. They grow more outward. There's a lot more scaling to them. They tend to bleed a lot. You probably have seen these on people with their little kind of rhinoceros shaped horns or cutaneous horns, we call them, but they can be like basal cells. They can have an array of different, appearances. So some of them can be rough, red, scaly. Some can be an open sore that just isn't healing. Some of them can be brown. There's pigmented variants of squamous cells. Some can look like craters or volcanoes. Some can look like warts, and then some can look like this rhinoceros type horn. And then you can also get a squamous cell in like an old scar or trauma. So really important, especially with people with chronic wounds, etc. So these are two examples of some squamous cells. The bottom one is really classic. We have different variants of squamous cell, but like a keratoacanthoma is another type. But really scaly, kind of ugly looking. They bleed a lot, have lots of crust. Those have to be taken off, and then they're treated with Mohs surgery. The other thing about squamous cells, they can really happen anywhere. So main cause is UV damage caused by sun or tanning beds. Tanning beds are really, really bad for the skin, as we all know. Immunosuppression is also a risk factor for a squamous cell. They can develop in the mouth. They can be in the genital area. They can be under the nail and the toenail. And they could be on the ear as well, hiding. So all these pictures are pictures of squamous cells. The finger one is, definitely something to keep out on a look for. So actinic keratoses, we'll talk about those in a little bit. Those are precancers. I'll show you some pictures of those. Those can develop into squamous cells over time. So you also want to treat those. And then these squamous cells are generally very treatable when caught early, but unlike the basal, they can spread and metastasize if we wait. So we're transitioning into melanoma. So this one is the least common, but most deadly. It's the most serious form of skin cancer. It's uncontrolled growth of pigment-producing cells. So melanomas are the darker ones that we see, but we'll also see that they can also be amelanotic, which means they do not have pigment, and those are the scariest ones. They may appear suddenly, just de novo, or within an existing mole. The overall incidence does continue to rise. And then melanoma rates have doubled from 1988 to 2019. And then worldwide, the number of diagnoses is going up by more than 50% by 2040. So this is not great. But if we catch it early and we detect it early, patients generally do really well. If we don't and patients get advanced melanoma, it can spread to the lymph nodes and organs, which, can lead to death. So risk factors here, very similar. For melanoma, though, it's moles. So greater than 50 moles, large ones, atypical looking ones. Previous history of melanoma does make you at increased risk. Family history of melanoma as well. Same thing with the basals and squames, sun-sensitive skin, red blonde hair, blue-green eyes, history of excessive sun exposure. Indoor tanning is a huge risk factor for melanoma, especially in our younger patients. We've been having a couple cases of younger patients with melanomas due to tanning, very extensive tanning history. And then history of previous cancers, such as breast or colorectal, also increase your risk. So we'll kind of go through like normal versus melanoma. So this is very hard for, just clinicians to kind of determine what's what. We use a dermatoscope in dermatology, which helps us look under the skin and helps polarize the light so we can look at patterns. But in general, normal versus melanoma, we'll kind of go through a couple of things. So I always tell patients ABCD of melanoma. So benign versus malignant, what we're looking for. So for melanoma, you're looking for something that's asymmetrical, something that just does not match the two sides. It's just very, irregular. It doesn't look good. It kind of looks funny. Borders, the borders are very uneven in melanomas on that right side. It's just very jagged. It's not regular. Color is really important in melanoma. Usually you see two or more colors, but you can also see 4+ colors. And then melanomas are usually pretty large. We say a pencil eraser, the diameter, usually larger than that, 6 millimeters. And then they change, they evolve. A regular mole, ordinary mole isn't going to do much over time, but a melanoma will evolve. They'll change shape, color, size, and they look bad. So I always tell patients to try to remember the ABCDs of melanoma. This is just another representation of it that I thought was a little bit less busy, but asymmetry, border, color, diameter, evolving. So this is another sign I usually use in practice as well. I've seen it a couple times in the last couple of days, actually, is that it's a mole which stands out. It's called the ugly duckling sign. It just doesn't look like anything else the patient has. It just looks different. They don't have much on their body, and then they have this big brown thing just sitting there staring at you. You definitely want to take that off or send it to us to take a peek at. So these are examples of melanomas. They look ugly. This one on the bottom has 4 different colors, maybe even 5 different colors. It's just really irregular. They look like they're almost growing outward. The top one is a little bit more kind of, looks like more of a normal mole, but you could definitely tell it's evolving and that it's growing outward. Same thing here. This one is like a radial growth phase growing outwards. The one on the bottom has almost like a scar kind of formation in the center. Might be regressing. It's turning into like a white patch. So very, very ugly. These are very ugly melanomas. You can get melanoma under the nail. That needs a biopsy. Our surgeons help us biopsy that. But anything on the nail that's really thick, that's changing color, looks funny. You can have a normal variant of that called longitudinal melanonychia, but this is just too many colors in there. There's too much going on. It's very wide. And then you can get it in the eye too. You can get ocular melanomas. So you really want patients to make sure they go into the eye doctor as well, because that's hard for anyone but them to diagnose. You can get it on the feet. Those are usually more advanced. And then, you can get it in the hair-bearing areas too. So in the scalp, these things just don't look good. You want to take these off. So how do we protect ourselves from getting these skin cancers? What do we do? So really, it's about prevention. So we want to avoid the midday sun. It's really hot between 10 and 4. You want to wear sunscreen with high SPF as much as possible. Reapply every 2 hours, and we'll kind of go into the specifics of this in a second. Sun protective clothing is also super helpful for patients. You might not want to look like this guy on the boat, but he is really, really protected. He doesn't have anything exposed. And then, you want to avoid tanning beds, use sunglasses, hats, etc. So prevention is the best medicine. So you want to use kind of what we said, all this protective clothing, especially when it's sunny. Limit exposure between 10 and 4. It's really when you get the peak UV. Avoid tanning beds, use sunscreen, seek shade when the sun is overhead. Really be careful near water, snow, sand, because those kind of substances reflect the sun's rays. And then you just want to keep an eye out on your skin. if any changes, you just call up your dermatologist right away and they'll usually fit you in. Just because, you know, if you have a spot that you're worried about, we should take a look at it. And then definitely visit us. So this is our group. We have a lot of doctors. I think I counted the other day, Sarah can tell me, 21 plus. We have a lot of mid-levels too, so this doesn't even include the mid-levels because I couldn't fit it on the page. But we have tons of offices, tons of doctors, and they're all excellent. So, you know, here in Shelton, we have the office. We have multiple doctors that are working there. I'm in Oxford, which is very close. So really, we do have a great online booking system where the patient can book like the morning of the appointment. It's very easy to use. I've tried it myself, and they get same day appointments, especially if they're worried about something, a spot, etc. We have a lot of providers that can help. So everyone asks me this, what do I expect at a skin check? I have a lot of patients that come in really, really worried about skin checks because they, you know, hesitant. They don't want to be in a gown. They don't want anyone to look at them. But we really make it easy. I feel like in dermatology, everyone, you know, at the end says that was actually not that bad. We try to make it as friendly as possible. So we have a medical assistant, scribe. They come take the intake. They're very good, usually very nice. They get the patient really comfortable. They change into a gown. We keep them as covered as possible, kind of to their comfort level. We make, you know, exceptions for, you know, people who don't want to take off every single article of clothing. Make them quick, efficient, so the patient doesn't feel like they're in the, you know, room standing there. And then we have a scribe in the room, so for documentation purposes as well. And they usually kind of hang out in the corner and just, you know, scribe down what we're talking about. We do use a dermatoscope, so that's that device in the corner there. Mine looks a little different. That's a little older one, but it does polarize the skin. So there's polarized and non-polarized. It helps us look underneath the skin. I can look at the lesion. I could see underneath it. I can see patterns, and we're really trained in dermoscopy, which is kind of an art in dermatology. It takes a while to kind of understand all the patterns and different things that, you know, skin cancers can look like. So that's that light we're looking with. If anyone has been to a derm, and what is that thing they're waving around? So we'll kind of go into sunlight. So two types of harmful rays that reach the earth in the sun. So UVA and UVB. We probably heard a lot about this. Both of them can lead to skin cancer. UVA, so I always say A for aging. Those are the aging rays. So those cause wrinkles, age spots, sunspots, and they go through our glass windows. So I have a lot of patients that come in with a lot of sun damage on the left side, and I say, have you been, you know, sitting near a glass window for your work, or do you drive a lot? And the answer is usually yes, because UVA is not blocked through that window. And it really does age the skin. UVB is more burning ray. So it's the primary cause of sunburn. That's more blocked by window glass. Same thing with visible light. That's another form of sunlight that makes dark spots worse. So it really makes them darker. So tinted sunscreens, if you've heard of tinted sunscreens, have iron oxide in it. It blocks that visible light component. So we'll dive into this a little bit more. But everyone asks about sunscreen. There's a million on the market. You go to CVS, you see everything there. So which one do you choose? It's really hard for patients to decide what to pick. But the general rules are you want SPF 30 plus. I have people coming in with SPF of 8, and it's not doing anything. And you're really not applying enough even to get that SPF of 8. So really 30 plus. You want to put it next to your toothbrush, make it part of your daily routine, wake up, throw on some, you know, sunscreen with your moisturizer. So technically 1 ounce, which is the size of like a shot glass, covers the entire body. No one puts that amount of sunscreen on their body. It's very hard. I can barely do it. So, you know, that is kind of the recommended amount, but we're really not getting that amount. So apply to the dry skin 15 to 30 minutes before going outside. And then if you're really out there for a long time, you want to actually use a higher one, SPF 50 or higher, especially if you're swimming, exercise, biking, etc. You want to reapply every 2 hours. And then everyone asks about the lotion, the stick, the spray. So the spray, technically, a lot of people hold the spray really far from their body, so they're not getting enough coverage. The spray has to be really close to the body to get what you need on the actual body.
How do you get your back?
Yeah, you need help. Yeah, exactly. Or you wear a sun shirt. So sun shirts are so great because you don't need to put this like sunscreen on. The sun shirt protects you really all day. So I do recommend that if someone has no help, you know, applying it to the back. Sticks are really good for kids. You can throw it on the face. They don't complain that it says like wet and, you know, sticky. And then sensitive skin, people really like mineral sunscreens. We'll go into that in a second. They're called physical blockers. They have zinc or titanium in them. So we'll talk about that. I lately have really liked this Isden. It goes on really, really light. And same thing with Eucerin. These sensitive mineral ones, everyone thinks they're really white and chalky, but a lot of these newer ones on the market they really blend in. So tips, apply enough to cover all the skin not covered by clothing. So like you were saying, if you have a sun shirt on, you don't have to worry about it. You really don't. Most adults need about 1 ounce. We mentioned the shot glass to fully cover their body. Everyone forgets their feet, the tops of their feet. Everyone has burned their feet, your neck and your ears. The ears are really important. We get a lot of squamous cells on the tops of the ears, and your head, or wear a hat. Apply sunscreen to dry skin 15 minutes before. And then, we can also get it on the lips too. It's another place a lot of people forget. So there's all these kind of lip balms with SPF of 30 plus. You just want to reapply often. Reapply every 2 hours. And then the other thing is cloudy days. The sun is really strong on cloudy days, which we've all probably experienced before. So which one should I use? I get this question a lot. I said it's the one that you're going to use over and over. So I don't really mind whatever the patient wants to use. I say sounds good. As long as it's 30 plus, it's broad spectrum, because broad spectrum means it protects against UVA and UVB, and then 30 or higher with water resistance. So all of these are great, options. Eucerin makes great a line of sunscreen. So does La Roche-Posay, which you've probably seen a million commercials on. Yep. Neutrogena, yeah. Elta MD is another one that's more of a kind of dermatologist, office brand, but all of them are really exceptionally good. I've used all of them and tried all of them, and they actually, go on pretty nicely. And then we probably all heard of chemical versus physical. This is more of a preference. So the primary difference is the actives in these things. So mineral has titanium dioxide or zinc oxide, or both. That's a physical blocker. It reflects the UV rays mostly. It creates that physical barrier. Usually it's gentler for sensitive patients, and it's better for hyperpigmentation, melasma, etc. The chemical sunscreens, though, have all those really long names: oxybenzone, avobenzone, octinoate. There's a million. Homosalate. Those are their actives. Those more absorb UV rays, and they convert the rays to heat, and then that's released from the skin. They tend to be sheerer. They're usually more clear, and they have a ton of options: oils, serums, sprays, etc. Physical sunscreens also do reflect the sun rays, and so do the chemical sunscreens. Both do. And then whether you have a chemical, physical, or hybrid, they all form a protective layer that absorb. So is a higher number better than a lower number? So SPF 30 blocks 97%. So you're getting pretty close to 100. You're never going to get fully there. There's no sunscreen that can get perfectly to 100. Higher numbers last the same as the lower numbers. So the time that that they last is the same. But the issue is most patients, and myself included, only apply 20 to 50% of the amount of sunscreen needed. It's very, very hard to get as much sunscreen that you need to get that SPF. So putting on a higher SPF helps to compensate for that under application. So I do tell patients, whatever you can get on, at least 30, 50 to 70 are preferable, just because of that issue with the application. It requires a lot of sunscreen to get to that SPF factor. All right, so that's sunscreen. Any questions on sunscreen?
Yeah, what about children? Do they use different, is there a different set of sunscreen for them, or can they use the same as the adult? I have a little boy who's the redhead and the blue eyes.
Yep, they can use the exact same as the adult. They'll brand them as kids and sensitive.
Well, that's what I'm asking, if it's
water.
The same, but
it's really
virtually the same thing.
And I really like mineral sunscreens for kids because they don't care about being pasty and white. And honestly, a lot of these newer agents, you're not pasty and white. So I say whatever you get on them, reapply constantly every 2 hours.
What about self-tanners? My skin feels odd after I put a lot of self-tanners on. I've almost given it up, but without it, my legs during the summer are white and the rest of me is brown.
Yeah, so I advocate for self-tanners compared to tanning beds. I cannot stand tanning beds, and I have a lot of patients that have tanning beds in their homes, in their basements. Yeah, and so we'll cut a skin cancer off that morning, and they're going in at night, and I can't do anything to get them to stop. I say, what can I do? Yeah, it is, and they're addicted to it, right? So I say self-tanner is completely fine. I know what you're saying, that type of effect where if you don't put it on, you really feel like you're getting a totally different color than the rest of your body. But the self-tanners, there's really not a great one that I can recommend, unfortunately.
Yeah, I just want to mention there's something, excuse me, EWG, Environmental Working Group. You can get an app on your phone and then you can scan any product to see whether it's safe, because there's still some, like, I think like what, oxybenzene, and there's still some things in, or phthalates, that are in some of the, brands, some of the, sunscreens.
And there was
So-
a whole, you guys probably saw that whole debate on the benzenes in sunscreen. So unfortunately, benzene should not be in sunscreen. It's a contaminant. So there's a ton of like
Good to know.
news. Yeah. So there's a news article saying that sunscreens are causing cancer with benzene, but those weren't supposed to be in there in the first place. It's a contaminant. It was a byproduct of their processing, whoever was making it, possibly from the ethanol in the manufacturing process. But benzene shouldn't be in sunscreen. They shouldn't be there. So really important to know, because the media goes crazy, right? And tells you that sunscreen causes skin cancer, but that wasn't supposed to be there in the first place. So I always tell patients, if they bring that up, which they do a lot, I say mineral sunscreen is the way to go. It's the best form of sunscreen. It's a physical type of blocker. It's not absorbing.
I guess I never looked, 'cause my son and I, we both have really sensitive skin.
Yeah.
Do you have to look for it to actually say broad for it has to have like that?
Yeah,
verbiage
you
that
want it
you're
to say
looking for?
broad. So like, for example, I'm going to go back real quick. So these guys all say it somewhere. So see 50 broad spectrum SPF
yeah,
on the second one. It says it right here on this one as well.
Okay,
And then same thing with Neutrogena broad spectrum SPF 50. Same thing with Elta MD broad spectrum. So that means UVA, UVB. You really want both, because you really want to prevent the aging and you want to prevent the burn.
gotcha. Thanks.
So it should say broad spectrum. Yeah, sure. All right, so this, let's go back here. All right, so we're gonna go over some common things. So a lot of times patients come in and say, I have this lesion. And there's a lot of different words and terminology for lesions. So actinic keratosis, which I was mentioning before, that's a precancer. So if I say it's a actinic keratosis, that means it's gonna, possibly eventually turn into a skin cancer over time, but it's a precancer. Seborrheic keratosis, all day long we diagnose these. That's a wisdom spot. That's what I say. It's kind of an age spot that we get after 35. They're those, we'll show you pictures, but they're really kind of waxy, pigmented. They almost fall off. We'll show you that. Lentigo means sunspot. Skin tag, we all kind of know what a skin tag is. Benign nevus or dermal nevus means benign mole. Epidermoid cyst means cyst. Sebaceous hyperplasia means oil gland. Cherry angioma means benign blood vessel, and dermatofibroma is a like scar-like growth. We're going to go through those. A lot of patients have these on the face. They're worried about skin cancer. We use our dermatoscope to look at them, but a lot of times these are just benign. These are moles, nothing to worry about. A lot of times they do have hairs growing out of them too. That means they've been there usually for a long time. Everyone thinks of these as liver spots. So are lentigos, lentiginous, just means sunspot. Directly from the sun over time, increased exposure increases your risk. Can be on the hands, can be on the face, can be really anywhere, chest, back.
Can you get rid of them?
Yeah, so it's very hard. So a lot of people use like topicals over the counter with hydroquinone. That doesn't work, unfortunately. So really laser devices are really the only way. Sunscreen to prevent new ones. And sometimes retinols help lighten them, but it's hard to get rid of them once they're there. Yeah. So oil glands, sebaceous hyperplasia, these are those kind of like yellow looking things. Patients are always worried about these things on the head. I have a skin cancer, but they're actually an overgrowth of oil. To get rid of these, we have to use cautery or a laser type device. These are the ones I was mentioning before that everyone's seen. These are those really nasty looking kind of warty seborrheic keratoses. These are genetic. Mom and dad probably gave them to you. And that I have seen patients with that level of them on the right side, and they're just huge. Really, the only way to get rid of these is by destruction methods. So liquid nitrogen, biopsy, etc.
And those are all benign,
Yes.
typically.
Yeah.
Do they come back after you just dry them?
A lot of times they do. Yeah, it just depends. Maybe a year, maybe 2 years, maybe never, but a lot of times they do come back. But the cosmetic outcome is pretty good because these sit on top of the skin. So it's not, they don't usually create a scar when we take them off. Cherry angiomas, everyone's seen these too. They're all over people. Genetics, mom and dad. People worry about these. Same thing, laser, cautery to get rid of these, or, you know, a biopsy, but usually not necessary. They bleed a lot though. So if you scrape them, they bleed. These we see all day long. You probably have seen patients with kind of that crusty, you know, scalp. And they're hard to treat, especially when it's advanced on the scalp like this. They have a lot of sun damage. I do multiple modalities to get rid of these, but they're crusty. I say they feel like sandpaper. If you touch like a patient's skin, patient's nose, patient's head, it feels like sandpaper. If you close your eyes, you can feel it. Those have to be treated. Skin tags. I always tell patients, please don't use that over the counter home strangulation. I have a lot of patients come in with the rope that they tie on, a little yarn that they tie on, and they can't do it, and then it's bleeding everywhere, so they just don't work. We numb them up. We put a little needle in them. We use a device to get rid of them, and then we stop the bleeding. Because if patients are doing this at home, they can't stop the bleeding. That's part of the problem.
Do they come back often?
They can.
Same place?
Friction a lot of the time. So even necklaces, friction, areas that are constantly rubbing, yeah, they tend to come back. But they're not hard to get rid of in our office, really quick. It's more of just that home stuff doesn't do it, and there's no way to stop the bleeding.
What do you use to get rid of it again?
So I use, in my clinic, I just numb it up with a quick needle. I kind of pop them up. I use like a Gradle scissors, and then I use some cautery to stop the bleeding. Skin tags always have a bleeding base. They usually surprise me. I'm like, oh, this will be easy, but they always bleed. They have a blood supply to them, and patients tend to, you know, bleed for a while. So you really need to cauterize.
What causes the skin tag?
Usually it's just friction, rubbing of the skin. That's really what it is. Yeah. Collar around the necklace, armpits, you got friction all day, groin. They're really friction based.
Do liquid nitrogen products work?
They do on the small ones,
Okay.
not the big ones. The big ones have too much of a base to them. So yeah, the small ones work. They tend to fall off. Cosmetically though, they don't look as good as the Gradle excision method. Cysts, we've all seen cysts too. They usually have a central pore to them. They can be blue, etc. We have to cut these out. They usually don't go away. We can also inject them with Kenalog to help them kind of, if they're really inflamed, go down, but you got to cut those out. Dermatofibromas, these a lot of people see on their legs. They think they're skin cancers. They trick you. They look like skin cancer. But they're actually firm. They're hard. It's from a bug bite scar trauma, usually on the lower legs of females after shaving, etc. I see these a lot as just like the chief complaint because they do look scary. And then like the last minute, I just always talk about just skincare products for photoaging. This is my most asked question, I think, in clinic. What do I use? What do I do? There's so much on the market now. It's so hard for patients to understand what they should be doing, what they should be using. So I have this handout that I give to my patients. In the AM, you want a gentle cleanse. Cetaphil gentle cleanser is really nice. It's bland. There's not much in it. For patients who want to, you know, worry about photoaging and want to have really nice skin, you want to talk about vitamin C serum in the morning. It's an antioxidant, it protects against free radicals. It does well for hyperpigmentation, wrinkles, etc. And then always, without question, sunscreen in your moisturizer. CeraVe AM makes a really nice one. And then PM, same thing again, just a gentle cleanse. Some patients don't need cleanser twice, you do it once. And then retinols for patients really worrying about photoaging and want to help lighten sunspots, etc. So retinols come over the counter or they come prescription. So tretinoin down at the bottom is a prescription strength that your dermatologist can write for you. It's really cheap these days. You can get it from specialty pharmacies, etc. And you always want to moisturize after the retinol. It's very drying, it's irritating, your skin will start to peel. So this is kind of the you know, very, you know, early type of photoaging, you know, treatment you want to do. There's a million other things you can add here. It's just how involved your patient wants to get, but this is where you start. And then same thing, derm tested products. So La Roche-Posay is a great brand. You've seen a lot on the television. They do a lot of testing on their products. CeraVe moisturizing cream, same thing. Aquaphor is fantastic for healing. CE ferulic is another vitamin C, but all these products up here, derm tested, really well trusted, etc. I believe is probably it. Yeah, that's it.